Mom deserves the best, and there's no better place to shop for Mother's Day than Whole Foods Market. They're your destination for unbeatable savings, from premium gifts to show-stopping flowers and irresistible desserts. Start by saving 33% with Prime on all body care and candles. Then get a 15-stem bunch of tulips for just $9.99 each with Prime. Round out Mom's menu with festive rosé, irresistible berry chantilly cake, and more special treats. Come celebrate Mother's Day at Whole Foods Market.
Welcome to Pharmacy to Dose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Now let's hear from our sponsor, QXMD, before we get started today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. I'm going to go a little off script there. If you haven't had a chance to dive into all the resources QXMD has, especially with everything happening now, it's really great. I encourage everyone to take a peek if you get a second. Now, a couple quick things. For those keeping track on Twitter, the official champion of the listeners bracket of the critical care medication March Madness bracket was norepinephrine, and in a landslide. Now, it wasn't surprising that the norepi won, but just the manner it did was impressive, just blowing everybody out. So thanks for all those that participated, listened, voted, everything that came along with it, especially to the bracketologists and things who took some time to come on. It was a fun distraction, and I appreciate everyone joining in. Now, another update. So Andrea Newsom and I just finished recapping the first book in the Pharmacy to Read book club. Now, if you want to go back and read, we have a little bit more time on our hands. Some of us do right now. The book was 12 Rules for Life, An Antidote to Chaos by Jordan Peterson. And I know there's kind of a lot going on in the world right now, so we didn't have tons of discussion within the Goodreads group, between all the different members. But if you've read the book, go check out some of the discussion questions. You go to goodreads.com and search Pharmacy to Read, T-O Read. And on the Twitter account, at Pharmacy to Dose, I posted kind of some summaries of the individual rules, and I'll post those on the website as well, pharmacytodose.com. Now, Andrew and I also want to announce the next book. So remember, it's a quarterly kind of book club, and the next book is going to be In Shock, My Journey from Death to Recovery and the Redemptive Power of Hope by Dr. Rana Audish. Now, with everything happening, this should be a timely read for many of us. And if you remember, one of our previous guests and friends of the pod, Morgan Jones, said this should be required reading for anyone working in the ICU. And we completely agree. That's why it's going to be our next book. So definitely encourage everyone to go get that, maybe start reading. More to come on that in the coming weeks to months. Now, lastly, I'm going to continue working to bring on guests talking about both kind of our classic critical care related issues as well as, the COVID-19 coronavirus related issues. Our knowledge is rapidly growing and changing related to that. So I want to work on bringing people on who can talk about the best information and evidence and something that all of the listeners, I think, will get some value of. But then we don't want to turn this into necessarily a COVID-19 podcast. There are already plenty of those. So we'll work on kind of getting you a decent balance in the coming months as we deal with this pandemic. It's a treat today, ladies and gentlemen, because I am joined today by Dr. Aaron Cook, and we're going to discuss the management of cerebral edema in neurocritical care. Now, Aaron is the clinical coordinator of neuroscience and pulmonary critical care at the University of Kentucky UK Healthcare. Now, Aaron is also an associate adjunct professor at the University of Kentucky College of Pharmacy and is the PGY1 Pharmacy Residency Program Director for UK Healthcare. And I've said this before here, but I'm going to reiterate it. I'm at the point now when we get guidelines that are released, the first thing I like to do is glance through the author list, looking for pharmacists and kind of the multidisciplinary team involved. And that is one of the reasons why I asked Aaron to join me today. He is the first author, the lead author, on the newly released guidelines for the acute treatment of cerebral edema in neurocritical care patients. So what we're going to do is kind of discuss the guideline development process as well as then dive in to the actual guidelines themselves. So Aaron, glad you could join me today. How are you doing?
I'm doing fine. Thank you very much for having me today.
Absolutely. So what's it like in Lex Vegas? Also I think referred to many as Lexington right now, because, most of the time, late March, early April, I think many people thought this was the, University of Kentucky would kind of be cutting down the nets and everything. Is it a little somber in the bluegrass state?
Yeah, we're definitely missing what we were hoping was another championship season, but it's given the circumstances, it's a bright and sunny day today, and Kentucky's faring as well as anybody in the current situation. So we're thankful for that.
Yeah, you're absolutely right there. And I want to kind of get into the guidelines and the development and things like that. But at the end, we're gonna talk about some quarantine entertainment, maybe some grocery store shopping lists. So we'll put a pin in that, and we'll save that for the end here. Now, kind of going into the guideline development, when you look through kind of the methods section, these guidelines were commissioned by the Neurocritical Care Society. So walk us through that process. Did you know that this would be kind of a part of your duties as a chairperson, or is it one of those kind of like surprise, you got an email and the whole process led from there?
Well, that's kind of where the story started, because I, quite a few years ago, Gretchen Brophy invited me to be a part of the Neurocritical Care Society Guidelines Committee. So I served on that committee, as well as being a co-author on the coagulopathy reversal guidelines, which were published several years ago. As I moved on in that committee, I became co-chair of that committee with Dr. Dave Cedar, and served in that capacity for 2 years. As I was leaving that role, the way that these guidelines sort of are identified for the organization to pursue is we ask the membership, what do you think would be valuable to have a guideline on? And then the board of directors essentially helps to figure out what the priority would be and all of that with the guidelines committee. As I was leaving that, it came to us as an osmotherapy guideline, is what it was originally. And so the part of the discussion was who would be a good chairperson for this. And in our discussion, I was really knowing that was going to be a very pharmacotherapy heavy guideline. I was advocating for a pharmacist to be a co-chair of the group, and ultimately it ended up being me. And so that's kind of how I got put into that spot. But it was advantageous because I had been with the guideline committee for a while, and so I kind of knew the ins and outs of the process, which made the whole thing a bit easier.
So even though there probably was still a little bit of a learning curve, it may not have been as steep as if you hadn't been involved in some of those other processes before.
It was definitely still a learning curve, but yes, it would have been much more difficult if I hadn't been familiar.
Now,
no doubt.
In total, how long were you working on these guidelines? Just to give everyone an idea of the amount of time it takes, maybe from the first email to kind of the that pre-publication print.
That whole process takes somewhere around 2.5 or 3 years, based on the way that we're doing it with the Neurocritical Care Society. We have kind of a mapped out process for how we want guidelines to go, just to keep people honest with timelines. To be honest, this guideline, we didn't follow hardly any of that, unfortunately. But we have, from the beginning, there's these discussions about what should the next guideline be. The organization votes, it goes to the board. once we sort of identify the topic, then that's when the work really begins, because then you need to start thinking about who's going to be on your team to work on this document.
And speaking about the team, I've always wondered how authors are chosen for kind of like a guideline or consensus document. So how were you able to get such a great mix of multidisciplinary co-authors, also from across the country? It's not like they're all from, for example, like the Southeast where you're working.
Yeah, that's totally intentional. So the Neurocritical Care Society, like many of our critical care organizations, has been really fantastic about approaching things in a very interdisciplinary way. And so there's nurses and nurse practitioners and physicians and pharmacists and all sorts of people involved in pretty much everything that gets done through that organization. And the guidelines obviously are no different. But we're intentional about male, female, U.S., international, neurosurgeon, neurocritical care, West Coast, East Coast, all of those kinds of things, to get as many sort of different brains and perspectives in the room as possible. With this one, because we knew it was going to be pretty pharmacotherapy heavy, I also kind of lobbied for maybe a couple of additional pharmacist resources than we would otherwise have on a guideline group like this, anticipating maybe that I wouldn't be able to have that hat on as the chair as much, at least during the data analysis and the writing part, the initial writing part. So we ended up having several pharmacists on this guideline, and they were all fantastic.
Now we love pharmacists here. Most of us listening probably are pharmacists or involved in critical care, but I have to ask, because your team searched and reviewed articles starting all the way back from 1947. Is the research librarian kind of the most underrated member of the guideline team?
Yeah, you could say that. I think that it's certainly the person probably that most people don't think about when there's another person in our group that I would say is underrated that we'll talk about here when we talk about evaluating the literature and using the grade process, I think. But yeah, it's a profession unto itself. And I don't think that most of us appreciate what a real professional, research librarian does. And, even though we had, a top librarian do our search, it's often, ours was so broad that it's fraught with difficulty, because you end up capturing all these publications that may not be pertinent. And so then the job of the writing group is to go through each and every single one of those articles and determine very quickly, is this going to be helpful for us, or is this totally unrelated? And, the hope is the balance. If you get a really broad scope of a literature search, then you're going to spend a ton of time eliminating articles that have nothing to do with your guideline whatsoever. But if you have a narrow scope, then my whole fear through this whole thing, I still wake up occasionally worried that, did we forget an article that we really needed to put in this guideline? And so if your search is too narrow, then, you may find yourself missing important publications once you get to the point where you're adjudicating the literature. And so it's a hard balance. And that was a big part of the work, especially early on.
Yeah, you mentioned kind of evaluating the literature, and within the guidelines, you mentioned that you use the grade methodology and the PICO formatting. So how much did you learn about that whole process as you were going through the guideline development?
A tremendous amount. And really that's where sort of the other, I guess, maybe unsung hero, where maybe people don't understand what the role might be in a guideline group like this. But neurocritical care and many other organizations that use grade or other similar tools like that to look at the literature, they will often have what we call a grade coach. So it's somebody who kind of knows the rules for how the grade process works, and they've gone to conferences that are really focused on the grade process and how they feel about handling different types of literature and all of that. I mean, it is an evolving science, and as we move forward, I think you'll see most organizations will have at least one sort of grade pro on their guidelines committee, if not on the writing group itself. For our group, Karen Hirsch was our grade coach, and Karen was just of tremendous value to help us figure out, like, well, how should we say this? Or is this, there are a lot of difficult to word recommendations in this guideline where we're trying to say there may be some value, but the data is not good. And, you don't want to say that you want to do it, but it's probably not unreasonable for some of these recommendations, and just how to word that. And somebody like Dr. Hirsch really helped us navigate that. But it's become a huge thing. And I think with, if you want to be involved in guidelines, getting involved in how that sort of process works is a really amazing way to have a skill set that almost no one has to be able to contribute at a high level.
This seems like one of those situations where, like, thinking about the grade and methodology and the PICO formatting, where I may think that I have an idea of what goes on, and then you actually kind of dive in and start this process, and then you realize that you truly knew nothing about this.
Mm-hmm. Mm-hmm. Yeah, and that happens throughout, unfortunately. So you start and then you start learning things along the way, or the grade coach says, no, we need to do it this way. And, same with the PICO questions. I think that really is, I think people are familiar with the PICO format from the standpoint of, I'm going to create a resident research project or my own research project, and I'm going to use the PICO format to really sort of help me hone my sort of population and study question. But in the guideline, you're kind of doing that, but to be the framework for the literature search. And there's very specific ways, and if we've spent the most time virtually over anything in the whole guideline on making sure that the wording and the intent of the PICOs were correct. All that work up front is what really took the longest for us to get that right. Because if you start down the wrong path, you're going to start asking for the wrong articles, and then you're going to be asking the wrong question, and then the wrong thing is going to be in the guideline in the end.
So has this process of, being involved with guideline development and guideline writing, has this changed your own research ideas and kind of practice or habits related to that? Because I ask because you're evaluating these studies, and I'm sure you've come across plenty of maybe ideas or research projects that were maybe done by residents or by other pharmacists that, before you might have thought were well done studies. And then once you go through this process, you realize, oh gosh, like they're inherently flawed. We can't use them as high quality evidence, et cetera. So has that kind of changed?
No question. Morgan Jones, who I know you've had on your program before, Morgan was a part of our group, and we had several conversations about how this is changing how we think about doing our own work or work with residents. Because, ultimately, if you're going to do that work, we would just constantly tell each other, like, we want to be doing work that can have an impact on guideline recommendations. And when we do small, heterogeneous, potentially biased studies, it's going to be downgraded to the point where it's not going to make a blip on a guideline, and it may be valuable to share and that sort of thing. And there's nothing wrong with those publications necessarily, but we talk a lot about, when we're really thinking about the serious research that we're doing, making it such that if we were going to grade it for a guideline, that it would sort of stand up to that rigor.
Now, you mentioned Morgan Jones, who is a big friend of the program who's on these guidelines as well. And yeah, I want to kind of highlight the other pharmacist member I was able to identify. We'll see if there was any more, but Sherry Tokumara. I may be saying that wrong, Sherry, and I'm sorry, from Hawaii, from sunny Hawaii. But were there any other pharmacy members on the team? I just want to be able to be sure to highlight them and kind of give a congratulation and kudos.
Yeah, absolutely. Sophie Samuel also in Houston is a pharmacist that was on that. So yeah, and Sherry Tokumaru. That's the nice thing about this organization too, and I think the pharmacy group within this organization, we've all worked together in some capacity, over the last really 10 years. And so that made it, I think, assembling the team. We talked about having East Coast, West Coast, Hawaii, and all of that as well. But you're also kind of looking for, and it's hard to tell this sometimes because you may not know this about people who are detail-oriented, people who are good at starting the writing, people who are good at finishing the writing, people who are good at sort of a macro view. And because you're also talking about project management over the period of 2+ years with very busy people. And so you can get experts in the field, right? And they're going to know all the literature, and they're going to have really insightful comments sometimes that make you think, oh man, I wasn't even thinking about that. But if they can't respond to an email or, attend a meeting when they're supposed to attend a meeting to give their thoughts, then as a project manager, which really the chair of the guideline is, it's a real pain. And so you really are kind of searching for both, like the people who have the expertise, but who that you can work with. And, especially within the pharmacy group, but as it turned out, our whole group was really awesome. Like it was just there were definitely days where I think we all wished it would end, but I think overall we really enjoyed the whole process and like working with each other. So if after a big project like that, if you can say that about your group, then that's a job well done, I think.
Now, your group only met in person twice. And I think that's commonplace for all these guidelines, because you mentioned you want to get a wide scope and you want to get a variety of practice areas and patterns and things. So everything else was done virtually, which is similar to what our lives have turned into now. So what unique challenges did that create, not being able to, for example, be in the same room, kind of in a conference table, looking at a projector per se, versus everyone being on a conference call or a virtual video call?
Mm-hmm. Well, back in those days, a year or two ago, virtual conferences were not what they are today, as far as our comfort level with that. And certainly being on site, we would take advantage of being on site at the annual meeting for neurocritical care. And then we met in Chicago as we were sort of going through all of our recommendations. And that was basically a day and a half for us to just hole up, put on a pot of coffee, get some food, and just like work the whole time. And, we adjourned, we went to dinner, and then we worked a little bit more and just knocked it out, because that's what we were there for. And so we tried to take as much advantage of the in-person time as we could. But yeah, it was a lot of emails, a lot of phone calls, the magic of shared documents and that sort of thing, really just kind of helped the whole process. I think now that, in this sort of era of using all these different video conferencing softwares and stuff because of the COVID-19 crisis that we're in right now, I think people would probably handle that a little bit differently and better than we did, because I think there are a lot of people on the calls that just weren't used to being on phone calls like that.
And now, kind of my last question, talking about the specific kind of the behind the scenes of the guideline, development and process. So how were disagreements dealt with or settled within the group? Because in an area such as cerebral edema management, there's certainly not as much high quality research compared to, say, maybe sepsis, for example. So you start to getting into evidence-based versus like anecdotal or practice-based kind of evidence. And so when people disagreed or things, how were those settled?
Well, that's a great question. That's why I think everybody being on the call or in person was really important. And so what we did was for each topic, let's say we asked a couple questions about subarachnoid hemorrhage. And so really we had really two people working on all the articles for the subarachnoid hemorrhage questions. And they came up with the sort of evaluation of the level of evidence and came up with sort of the first draft of what the recommendation should be. And they presented that to the rest of the group and defended that. If there is disagreement between those two people, for instance, I feel like this is a high quality article. I feel like this is a low quality article because of these different reasons. Then usually Dr. Shutter or myself, one of the two chairs, would be tied to one of those groups, and then we would help sort of figure out which direction we were going to go. We'd kind of hear both sides and then move on from there. And that was our setup, for all of that. But then once we put all the recommendations out on the table, it was kind of up for everybody to weigh in, because in reality, everybody was a neurocritical care practitioner, and everybody had a pretty good handle on pretty much all the literature that we were talking about. I do think we're really fortunate where all of our discussions were really focused on the things that we read, the grade of what we read, and the temptation, I think, for most of us is to also just layer in our own biases and experiences and anecdotal experience. And we talked about a lot of that, but I think we were pretty good about knowing when we were talking about anecdotal experience and not necessarily letting that go into the recommendations if it wasn't warranted or if it didn't match what we had read and what our analysis said, if you take my meaning. It's tough because, like you said, the level of evidence is relatively low, across this whole guideline. There's almost no strong recommendations or high quality evidence in any of these questions, and which made it a little bit more difficult.
I mean, it sounds like the key is getting a really good team and group and everything. It downstream is much easier, because it sounds like if you have difficult or stubborn people, it could really put a kink or a stop in making progress through something as long as this could be. So it sounds like kudos to you for getting a really good team.
Probably luck more than anything else, but I'll take it.
I love that. Normally you don't get to hear about the behind the scenes unless you're lucky enough to go to conferences or to hear the speakers kind of in person. So that was great. I really appreciate kind of taking us on the path of from beginning to end of these guidelines. Now, the guidelines specifically focus on the management of cerebral edema, and they address within them kind of elevated ICP, intracranial pressure. Now, for those who may be unfamiliar, what do these terms mean, and what type of patients kind of experience these issues, generally speaking?
Well, we termed it as cerebral edema first off in the beginning of the guideline, because we wanted to acknowledge that many neurocritical care patients may have edema, may have elevated ICP, but in a lot of these patients, we don't actually have an ICP catheter, right? And so you may not exactly know what the number is, but based on scan, based on the patient's neurological exam and those sorts of factors, that the patient has cerebral edema. So here we're really manifesting as diminished neurologic function. And I think for the most part, I think you can, in your mind, if you want to say, find and replace cerebral edema and elevated ICP, then you can kind of think about it that way. In the document, we almost always said cerebral edema or elevated ICP. Virtually every time that we mention one, because we wanted to sort of pair them together, but still acknowledge that sometimes you just don't know what the ICP is. But if you know that the pupil's dilating acutely, then you should probably go ahead and do something.
Now, before we dive into what's covered in the guidelines, let's kind of just briefly mention what isn't covered, which what stood out to me at least is the treatment for, refractory cerebral edema or increased ICP.
Mm-hmm.
So was this just deemed out of the scope of these guidelines, or is it more that there's just no data and it's all practice-based, and so it would have just made it really more challenging?
Well, that's a great question. We had a lot of discussion about this early on in the guideline process to determine whether or not this was within the scope. And once we got to talking about what this would mean, we pretty quickly determined this is probably outside the scope. Because it wouldn't have probably just been refractory cerebral edema and pharmacotherapy, like with pentobarbital or something like that. It would have probably also been targeted temperature management and hypothermia. It probably also would have been decompressive hemicraniectomy and, several other things that are maybe non-pharmacologic. And so we really kind of felt like, one, those were sort of being addressed with other guidelines, like the Brain Trauma Foundation guidelines and that sort of thing, even though osmotherapy is addressed by that too. And other organizations like AHA. We had just finished a targeted temperature management guideline, sort of a how-to guideline within neurocritical care. We didn't want to duplicate any of that as well. So if it was because there was no data, then half of our actual guideline wouldn't have been written either. So it wasn't that for sure. You do want to start with some, reasonable amount of data to do a guideline. Otherwise, it's not really a guideline. It's probably more like a, consensus statement or even a white paper, depending on how weak the actual evidence is. But yeah, that's why we didn't go with refractory so much. It's just well beyond the scope of what we were going to be able to do. And I think if we had gone that route, then we would have definitely needed to have drafted a few more neurosurgeons in the mix to really lend that expertise from the surgical management side and all of that as well. And so that we made the decision not to do that, just keep it simple with the acute management.
So these guidelines address 16 questions kind of relevant to the treatment and monitoring of cerebral edema in neurocritical care patients. So was there, how long was the initial list? Was it did you have a lot of questions that got pared down into this 16, or through the process it started and ended with 16 total?
It was a few more than that, and we really had to trim it down, and 16 was probably more than what we needed to do to begin with. We did have some other topics in there. I think we were really interested in some novel things that haven't really been talked about in guidelines yet, like cerebral edema related to CAR T therapy and that sort of thing, and having some statements on that. But at the end of the day, we really just kind of, it sort of morphed back and forth. Some of the questions fell out and came back in, depending on, the direction that we ended up going. And so that took a while to think about what topics we wanted. And the discussion early on, and you'll find in the guideline, was that we really don't want to make this a treatment of ICP and neurocritical care and just act like all the neurocritical care patients are the same and that their pathology is the same. We really wanted to say, okay, we're going to have a couple questions on subarachnoid hemorrhage because their pathophysiology is totally different than a traumatic brain injury. So we're going to ask a separate question on TBI. We're not going to suppose that hypertonic saline or mannitol or any of these other therapies work the same in all these different therapies, in all these different disease states. That's why there's sort of so many different questions, because we're looking at different populations within neurocritical care.
And that would explain, if the listeners are going through this guideline, that might explain to them why there isn't just a general treatment recommendation, because it sounds like the etiology of the cerebral edema or increased ICP really plays a part in how you should then manage it, correct?
Yes. We think so. I think ultimately the data really looks kind of similar from study to study to study. And the reality of it is many of the studies were heterogeneous, and they had some TBI patients and subarachnoid hemorrhage patients, and they reported the data all together. And sometimes they gave subgroups based on the diagnosis, but sometimes not. But we didn't want to sort of presuppose that when we did the guideline. We wanted to let that play out.
And you hinted at this a little bit earlier, but generally speaking, how would you describe the quality of the evidence or published research for the treatment of cerebral edema, with the scale for those listening kind of being from very low to high?
So let me preface this by saying that the people who do research in this area are probably very nice people, and I'm sure that they worked really hard to do the things that they did for their patients and to report it in the literature. But that being said, the quality of the literature based on grade for most of these areas is low. But I just hate the feel of saying, well, the quality of the literature is low, because that makes you feel like that you did a bad job with your study. But that's kind of how the grade turns out.
Well, and there were probably times as you're reviewing some of these articles that you're emailing someone on the guideline team to let them know, like, hey, I'm sorry, we just reviewed X study and it's unfortunately low quality of evidence, right? Did that happen throughout the course of this?
Yeah, there are several authors on the guideline who had papers that we included or that we considered including. And I mean, that's the nature of the beast. If you are asking for experts in the area to be involved with the guideline, they've probably published in that area before. And when we did that, we made sure that that those authors were not evaluating and grading their own manuscripts. And if and when there were situations where it came up where we were debating recommendations, like the recommendation statements, and those articles came up, we let that person talk because they wrote the paper, they know the data, but we also sort of had that sort of separate discussion of, like, yes, this person wrote this article, but we can't just let them drive the whole conversation. And I think between Dr. Shutter and I, we did a pretty good job of making sure that it wasn't like, well, my paper is going to be highlighted in this guideline and blah, blah, blah. I think we did a pretty good job of making sure everybody was fine with how we did that. But good example is one of the best studies on sodium concentrations in neurocritical care is by Morgan Jones and his group. And so, obviously he got to say his fair share about that publication, but in the end, we kind of made sure that the recommendation was from the group and not just from him.
Now, kind of diving into some of the subgroup patient populations, which subgroup had the most evidence for your kind of recommendation out of all the different groups you all addressed in these guidelines?
I think meningitis and steroids. We elected to look at that one, even though it's been sort of covered in some of the IDSA guidelines for meningitis, just from the standpoint of adult and pediatric dosing. We also included tubercular meningitis. And that was an area where we toyed with, do we even want to do that one? Like, that was one where some of those questions were out originally. They were in, but then they were out, but then brain abscess was maybe in there, and there's so many different types, EBD infection and those kinds of things. So we really had to hone that down into what ended up being sort of community acquired bacterial meningitis and TB, and that's probably where the most consistency of high quality of evidence was.
something I want to point out from those recommendations, something that I really liked is that, you have the strong recommendation for, the 10 milligrams of dexamethasone IV Q6 for 4 days from that landmark New England Journal of Medicine study. But then you also have a good practice statement right below of suggesting 0.15 mg per kg of dexamethasone Q6 for 4 days as an alternative dose for those maybe, at high risk of corticosteroid related adverse effects or with very low body weight. So I really like that. I feel like you can see some of the pharmacists shining through in terms of managing some of those adverse effects and things. So that was something to me when I looked at these that really stood out as a great addition.
Thank you. That is kind of a very pharmacist thing to do, isn't it?
Now, for patients who have a subarachnoid hemorrhage, or really with, I think you could say neurocritical care patients, more general, I think that when we're thinking of cerebral edema and that ICP management, we'll work to really drive up that patient's sodium level. And we're gonna, in the guidelines, even have that sodium specific target range that you want to bring that sodium level up to. So do you think that strategy is generally helpful of kind of going up and targeting that high sodium level? Did we find any data to kind of support this type of management?
We didn't, actually. It's really two separate questions. Do I think it's helpful? Maybe. I don't know. What is published, and does it support the practice? No. I don't think that it does. The data that we evaluated really in subarachnoid hemorrhage, and then sort of what we really did was try to get at, are you using continuous infusions of saline or hypertonic saline to target a sort of super therapeutic or almost super therapeutic sodium concentration because that this patient is going to swell, they've got a large hemispheric infarction or subarachnoid, and you want to make sure that you're certainly preventing hyponatremia, but you're sort of on the relative hypernatremia end of the spectrum to try to reduce the ICP burden or decrease the number of ICP crises that we have. And the one study that really looked at an actual range did not show any difference in ICP issues. The studies that people commonly will reference to support that practice don't actually look at a range at all. They might look at a delta, like a delta of 5 in the sodium concentration or something along those lines. But that doesn't tell you what the actual serum sodium should be. I think that's the way that most people practice is let's get their serum sodium up to this certain level and maybe not as a delta of 5. So it's difficult. This is one of those areas where you can certainly see that it's plausible physiologically that raising the serum sodium might reduce ICP crises and all these different things. And it may ultimately be true that it's helpful, but I don't think there's any studies right now that help us understand if it's true. It's a lot like what we're dealing with COVID right now. Some of the drugs we are using may actually be helpful, but we don't actually know what's true right now. And so it's the same in neurocritical care.
And so, personally, because it sounds like the data is not really there. Like personally, how do you practice? Do you look for that delta or do you target the specific sodium?
I kind of view it. So I think being a pharmacist, I also need to be able to work with the multidisciplinary team and understand what their goals are. And often in my group, they will target a specific serum sodium. And, now that I've been through this process, I'm not a big eye roller anyway, but I definitely I try not to roll my eyes because I think there are times when people act like this is standard of care. When in reality, you look at the strength of the literature and it's far from standard of care. So my thought really is you should definitely work hard to prevent hyponatremia. We know that that's bad for patients who are swelling. But like most things in critical care, I think if some is good, then more is better, right? and that's kind of where we are with this. And I don't, And like most things in critical care, that's not usually true. Being in the middle somewhere is probably actually what's best. What's interesting about this whole thing is people think about it in terms of efficacy all the time. Is it reducing my ICP? But we explore the safety as well. And the data for safety, or really for harm for sodiums above 155, is much stronger than the data supporting targeting higher serum sodiums for efficacy. So actually, if you looked at the literature, you would say, based on that, this therapy looks more consistently harmful than it is helpful by targeting a high serum sodium.
Now, out of the patient subgroups, talked about or looked at in these guidelines, does any of them have evidence that we should be using one kind of osmolar agent rather than another? And as I'm saying that, I worded that question wrong. Basically, what I'm asking is, the osmolar therapy we're talking about is hypertonic saline and mannitol. Are there any subgroup of patients where we should truly be using one over the other?
Yes, probably. we suggest things. So it's not necessarily one where I would say absolutely we should be doing this. But in our recommendations, both for intracerebral hemorrhage and for traumatic brain injury, the committee felt like that, if anything, the literature leans toward hypertonic saline over mannitol. There are some studies that say that they're equal. There's some studies that say that hypertonic saline maybe has some advantages in these two specific populations, ICH and TBI. And so in our recommendations, we say in both areas, we suggest hypertonic saline over mannitol. Now, really in both situations, mannitol's fine. And in reality, if you're going to fiddle around for an hour trying to get the perfect drug instead of treating the patient in 15 minutes when they have a severe problem, you're probably doing that wrong, right? Like, I think we didn't address timing, but I think in practice, whatever's closest to you is probably best. And so if you have one at the ready and the patient's dying in front of you, then I think you give that. Even if we suggest hypertonic saline over mannitol, if it's going to take you 45 minutes to get your hypertonic saline and 5 minutes to get your mannitol, it should answer the question right there. That's the only place that we did that. And that I felt like that might be a little bit of a controversial recommendation, just because the literature is a little, it's pretty close there, but we felt like that was a fair representation of what we read.
That really reminds me about another critical care or a neurocritical care related issue. One of our first guests in status epilepticus with Corinne Berger, and that's exactly what she was saying is, look, we can argue about the small differences in efficacy, but if you can get drug X 20 minutes faster than drug Y, then X should be what you use every time. And it sounds like that is where you were thinking as well. Absolutely.
Same thing.
Now, I want to highlight a recommendation for patients that present with acute ischemic stroke. And it stood out to me because it's one of the only, I guess you'd say, negative recommendations in the entire guideline. But the guidelines suggest against the use of kind of scheduled or prophylactic mannitol therapy in those patients. Now, why is that?
Well, we actually found a couple of articles that describe using scheduled mannitol in stroke patients, sort of under the supposition that these patients are going to swell, and so we're just going to dose them before they're swelling to try to prevent that cytotoxic edema and that you often get with especially big MCA strokes. And the outcomes in those studies were bad. The patients ended up seeming to do worse. And so it's in some ways it's analogous to what we're doing now with hypertonic saline and chasing a sodium target to some degree, but it was really looking at scheduled mannitol doses, like every 4 or every 6 hours.
So we've really been focusing a lot about, osmolar therapy and reducing that ICP or cerebral edema. But when we think about outcomes-based research and things, does this treatment have any effect specifically on neurologic outcomes in any of these subgroups of patients?
I'm glad you asked me that, because aside from thinking about it in terms of the disease state, we also broke out a lot of the questions with, does it lower your ICP? And then the second question was, does it improve your outcome? Because I think we all understand that having an elevated ICP or rampant cerebral edema is bad, and it usually portends bad things for the patient. But there really are, in our research on this topic, and as we went through the guidelines, there are really no studies that have shown that treating ICP or edema, especially with osmotherapy, impacts your outcomes at all. So ICP is definitely a player and, probably a bad actor in this whole thing, but treating it doesn't necessarily mean that you're going to have a better outcome, 1 month, 3 months, 6 months down the road.
Yeah, I think that's an important point to kind of emphasize, is that, like you said, we're gonna work on managing those ICPs, and we're not gonna let, if we have the bad neurologic exam, et cetera, we're gonna help manage it, but that at the end of the day, we don't know definitively that this helps improve the ultimate outcome of these patients, and something where I'm guessing we probably need a little more research into, correct?
Yes, I think there are just so many factors. The one exception to that I should definitely mention is steroids and meningitis. We know there's some suggestion for reduced mortality. Certainly there's pretty consistent suggestion that you have decreased hearing loss and that sort of thing. But when you're looking at these really sick TBI and subarachnoid hemorrhage patients, there just appears to be a lot of other factors in addition to the ICP that affect their outcome, and not just treating their ICP.
I think if we took a poll of hospitals kind of across the country, I imagine that there's somewhat of a split between who administers hypertonic saline via just a continuous infusion, say, right, anywhere from 25 to 100 an hour, what have you, and then those who give the hypertonic saline in IV boluses. So help us settle the debate. We like winners here. So which way should we be using?
So we did have a specific question about this in the guideline, to look at the best method of giving hypertonic saline if you are trying to reach a specific sodium target or something like that. And we evaluated studies that looked at continuous infusion versus boluses. Unfortunately, there's really only one that looked at that, and there was no difference between the two strategies really with ICP or anything else. But with just one study, it was really hard for us to say that we're going to make a definitive recommendation, or even any kind of recommendation, just based on one study. Because while it was a nice study, we ended up downgrading it to sort of a low quality study because of the study design and other factors. So based on one low quality study, we weren't really doing a lot with making recommendations. So you'll see in the document that we basically say there's insufficient evidence to support one versus the other. There's no way we can really recommend a specific dosing strategy. So unfortunately, Nick, there's no winner, I guess, from that standpoint. And this is clearly an area where a lot of us are doing this. And as you mentioned, a lot of centers are doing it one way, and a lot of centers are doing it the other way. And it's an area where a lot of research needs to be done. And usually when a lot of people are doing it and the research needs to be done, hopefully one of the things that comes out of this guideline is, and we tried to layer it through a lot of what we wrote, is here's the gaps. Here's what we thought that we knew, but we actually don't. Here's where the work needs to be done, we think, based on what we see. And hopefully, if 3 or 4 years from now, there are publications that would fit really nicely in these questions that answer some of these, then really our goal will be fulfilled with how we kind of ended this thing up. Because knowing the gaps, we really felt passionate about, let's position this guideline to help us so that whenever we do this again, 6-7 years or whatever, we have some new stuff to really plug in that's high quality that can help us take better care of patients later on.
So up to this point, we really haven't talked much about, monitoring or adverse effects from this therapy. And when, we'll talk about hypertonic saline first. And when I think of common adverse effects, right, hypernatremia, metabolic acidosis, AKI, those kind of all come to mind as possible adverse effects. Is this what the working group found as well? And then kind of the second part would be, what should we be doing in terms of monitoring to help prevent these adverse effects?
Mm-hmm. It's a great question. We absolutely found that was true. What's been published has not really shown the metabolic acidosis as much, but I think anecdotally we kind of all talked about it, like we see that all the time, but and it may just be one of those things everybody knows it's there, and so nobody bothers to publish on it necessarily. But studies that use buffered saline largely haven't shown huge blips in the chloride, but that is one of the reasons why people might think about doing that, sodium acetate or sodium lactate or other sodium salts. We were really interested in looking at not just the hypernatremia aspect of using the hypertonic saline, but also the hyperchloremia. That's a big issue in other areas in critical care as well, with hyperchloremia and AKI. And so we explored that as well, and we found that sodium levels certainly above 155 have been associated with AKI, and then chloride levels as low as 110, but maybe 115, somewhere in that range. Anything above that was also associated with AKI. So we made a specific note, and every time that we send it to reviewers, people picked on this comment a little bit. So there's a good practice statement in the guideline that says you should monitor renal function and sodium and chloride. And that was a common critique, like, why are you being so specific? But I know at my facility, often we'll get we'll check a sodium, in the afternoon to see if it's changed, but we almost never check a chloride with it. We always just send a sodium and never just a basic metabolic panel or Chem 7 or whatever your institution likes to call it. But that was our argument, is chloride's a player here too. It's not just the sodium.
Now, our monitoring of mannitol is a little different for one fairly obvious reason, right? It's an osmotic diuretic, so we monitor that osmolality to help reduce that risk for AKI. But I think the question here is, what's more important to monitor and follow, the serum osmolality or the osmolar gap?
Well, in the guidelines, we came down on the gap as sort of the preferred, but that's also an area where we think we know what we're doing with monitoring mannitol, but it's amazing how little there is actually published that actually gets to that issue. And actually the best thing to monitor probably is mannitol concentration, but no one really has that readily available. The reason we settled on osmolar gap is it's the best surrogate for the mannitol concentration. And specifically an osmolar gap of greater than 55 gets you to a mannitol concentration that causes a lot of renal vasoconstriction and then the AKI.
Yeah, much of our monitoring for these agents is ultimately for the prevention of AKI. So let me kind of give you a scenario here. So say, a patient's osmolar gap is 30, or their serum sodium is 165, 170. But the patient's renal function is okay. It's holding fort. There's been no change, good urine output and all those things. What do we do in those circumstances? Should we panic? should we hold the course? Do we try to back off on our treatment plan? Like generally, what should we do if you're seeing one of those adverse effects, but you haven't seen the ultimate downstream adverse effect that we're trying to prevent?
Yeah, that's a great question. And that happens every day. So the two ways I think about it, one, it's an association. It's not necessarily a direct cause and effect every time. So it certainly should heighten your awareness. But it probably isn't going to happen every time. The other way that I sort of approach it is, what if you replace sodium with phenytoin and 155 with 23, and thought about it that way and said, well, we're kind of at the upper end and the patient's not showing symptoms of toxicity, but I know that if I give more, I'm pretty likely to start seeing some problems. So in that case, if it's an antiepileptic and you're at the upper end of your dosing range, you're probably thinking about what other therapies can I use to get to the same endpoint or to act as an adjunct. And that's the way that I would approach it with using osmotherapy agents. If you're treating ICP and having to give so many doses that you're up at the upper end of the sort of safety thresholds, then I think you can push patients there if you're monitoring. But then that's when you really have to scrutinize, have we done everything else? Have we hyperventilated the patient? Are they sedated enough? There's all these other things that you can do to help alleviate the ICP and the edema that are not osmotherapy, that you really that should be a clue for you to sort of take a step back and figure out what else you can do to help.
Yeah, that's a great analogy. And I wanted to ask that question because, like you said, I think this is something that in these patients comes up every single day as a potential, because we're doing the monitoring as we should. So I think you kind of helped illuminate a question that I think many of us are dealing with on a regular basis. So if this is even possible, try to summarize the guidelines in a few statements for us. What are some big key take-home points you'd like people to remember when they're thinking of the management of cerebral edema?
I think the first statement I would make is that none of this is standard of care. The data is so weak that you can be as passionate as you want about one drug or another, or one concentration or another, but there's just no leg to stand on for almost any of this to make it standard of care. So there's a lot of some people don't like that, but there's a lot of wiggle room. And you can do different things. And so I like that because you can let the patient be your guide. But there's no way to really make a standard of care for almost any of this. Two, there's enormous potential for good research that will impact future guidelines and, more importantly, impact patient care tomorrow if people look at what is missing in all of this and try to fill those gaps and advance the field further in that way.
And then kind of wrapping up, because, the guidelines and you've mentioned this throughout the podcast, there's a dire need for high quality research. What were some of the most common issues with studies that you all reviewed or evaluated, things that we can help kind of learn from and help make the level of evidence a little bit better for future guidelines?
This is what really stuck out to us when we were grading the literature is, if you're doing a study and you're including brain injured patients and intracerebral hemorrhage patients and subarachnoid hemorrhage patients and status epilepticus patients all in your neuro ICU, and you're acting as though they're all the same when it comes to outcomes or treatment response and those sorts of things, that is called heterogeneity in your population, and that's a reason to downgrade your study. So that's one aspect, is just sort of lumping. Now that's hard because most of us would do that if we knew that the sample size was going to be low. Well, I'm only going to have 10 hemorrhagic strokes, and nobody wants to publish a study with just 10 patients either. So it's a balance between being heterogeneous in your population, but also having a reasonable sample size to where you can actually show what you wanted to show. Sometimes the endpoints were not exactly as clinically applicable as you would want, or maybe they were so, looking at mortality, for example, with a mannitol versus hypertonic saline study. Now we know that's probably not the best endpoint to look at. And so thinking about it in terms of what's a real outcome or endpoint that would be meaningful, that would help us understand which therapy to use, but maybe is not so grandiose that, you're gonna solve the world's problems with this one study. Being very focused in your study and then using that to advance to the next study, I think is an important piece. One of the hardest things that we had to do was look at meta-analyses. And in the grade hierarchy, meta-analyses are the top. They are sort of the paragon of the literature that you would be able to evaluate. But often in the meta-analyses, as you probably know, you can easily make a meta-analysis with a bunch of low-quality studies. And then magically the meta-analysis becomes the top of the pyramid for the grade scheme. And we really scrutinize the meta-analyses a lot because within the meta-analyses, often there was heterogeneity with the studies, heterogeneity with the population. And we really had to be careful with how we graded the meta-analyses. And so I would say if you're doing a meta-analysis, that's definitely an area where you need to be careful in how you are handling all these small studies. I mean, that's the value of a meta-analysis, is you can take a lot of small studies and pool them together. But if it's a muddy pool, then it's really hard to see what's at the bottom.
It sounds like, in a sense, it's almost like a house of cards where, you have this meta-analysis at the top, but it's been, it has all of this low quality stuff that when you end up, swishing that away, the house can kind of implode on itself a little bit.
Yeah.
Well, I'd be remiss kind of not to end our discussion with a couple more lighthearted questions here, kind of thinking about shifting to our quarantined life right now. So I think all of us, we're going to the grocery stores, we're stocking up a little bit. I saw sales are up 300%. So what's the one item that you have to have? Now, we're not talking essentials like eggs, milk, or what have you, but what's maybe something where you're going to the grocery store and you're definitely grabbing on the shelf to prepare for 2 weeks of being at home?
Well, I guess I would ordinarily say bourbon, but here in Kentucky, that's actually an essential. So it's, bourbon and toilet paper and then everything else. So I don't know. I think for my family too, I think bacon would have to be really high on the list.
Now I have a follow-up question. What's your go-to bourbon?
Well, that's a great question. I think Weller's right now, but that's really hard to get. But a good everyday bourbon, maybe Woodford Reserve or Eagle Rare or something like that.
I like that. Now, one thing I kind of want to do as we're in this period is to have the guests come on and give some entertainment recommendations. So do you have a movie or a TV show or even like a book that you've been reading recently that you want to recommend to the listeners?
So I'm probably a terrible person to talk to about movies or shows because I'm about 10 years behind. But I recently finished The Wire, which I thought was amazing. I think if I were quarantined, so my wife and I have had this conversation about if I have to undergo quarantine, because I become sick or whatever, and I'm living in the basement, of our house for 2 weeks. I think the first thing that probably goes on is Ken Burns' baseball. Everything that Ken Burns does, I think, is amazing, and his work on baseball is just amazing. So you need about 16 to 20 hours to do it. So it's like a Harry Potter marathon, which also would be fine for me too. But yeah, it's a significant time commitment, but it's amazing.
Oh, the wire is so great. Oh gosh, Omar coming. That is, a funny story related to that. So I did my critical care residencies down in Atlanta, and one of the first year residents at the time, he was like a born and bred. He was from Georgia, and he had taken a position up in Maryland, up in Baltimore. And technically, when you fill out those surveys, Maryland is in the southeast. Right. And so he's asking, he asked me, cause I was living up in DC at the time. Hey, what's it like in Baltimore? The Southern guy. And I just responded. I was like, just half-heartedly, I was like, just watch The Wire. That'll give you an idea of what it's like. Now we have some Baltimore listeners here. So again, that was a joke. If you haven't been to Baltimore, it really is. I want to come out and defend it a little bit. It is a great place to visit. Very fun. You have the harbor and all that, but you'd be remiss.
I love eating there. Oh. I love eating there.
Well, Aaron, thanks so much for joining me today. I think we all learned a lot about what goes into, creating those guidelines, and then kind of more specifically about the management of cerebral edema. Now, what's your Twitter handle for any listeners who may want to get in touch or reach out to you?
So my Twitter handle is amcook and then the number 0. And if you tweet me or message me, I will get back to you. But you'll notice on my Twitter that I am not a prolific tweeter. So it may take me a few days, but happy to hear from you, and very much appreciate the opportunity to come on and talk about this big piece of work and this awesome opportunity for pharmacists, and just hopefully something that's helpful for people in neurocritical care and across neurocritical care.
Yeah, Aaron, appreciate you. Thanks again for taking the time. So another huge thanks to Aaron Cook for taking the time out of his crazy busy day to join us today. And, also want to give a massive thank you to you, the listeners, because obviously this podcast, it doesn't exist without you all. So please send me feedback, either positive or negative, as well as any guest or topic ideas via Twitter or Instagram at Pharmacy to Dose, that's TO to Dose, or via email, pharmacytodose@gmail.com. Now, a quick aside, if you've looked or visited the Instagram page, I know it's been lacking. One of my quarantine resolutions is to start ramping that up. So if you haven't already, give us a follow. There's going to be more coming out on that. That's a promise from me. Now, on our website, pharmacytodose.com, you'll, of course, find the show notes that include background reading, guidelines, articles we reference in the discussion, including, obviously, the guideline we focused on today, and much more. And honestly, I'd love to hear from each and every one of you. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.